Hi everyone, I'm Skip, and today I'm going to give you some introduction of TMS. So this is our social medias, and you're willing to follow it if you have any questions about TMS or you're interested in TMS, you can contact us through these social medias. Also, you may follow us. And as for what I have to mention in this overview, first we will have a brief introduction to TMS, and next we will introduce some technical principles and effects of TMS. And then in the third and the fourth part, we will introduce some frequently used protocols of TMS in assessment and in treatments. And last, we will talk about some safety terms of TMS. And we have many text explanation in this presentation. And in case you are not listening clearly, the online voices. Now, I have chosen some of the important histories of TMS. First, in 1831, the electromagnetic induction was discovered by Faraday, and which is also the basic physical principle of TMS. And in 1985, the first TMS was developed by Bakker, and he successfully induced MEP by TMS, as you can see here. And in 1988, the figure of 8 coil came out by a Japanese professor, and China's first single pass TMS was also developed at that year. So this is Dr. Liao Jiahua, and he did the first Chinese single pass TMS. And in 1989, the first rTMS stimulator was developed by Cadwell. And for now, the rTMS stimulator can reach 100 Hertz. And in 2005, the theta burst stimulation TBS was developed by Dr. Huang in Taiwan, China. And this TBS is an optimized rTMS pattern, and it is also approved by FDA. So as you can see, FDA has approved a lot of applications of TMS, both in psychiatric or in neurology, for major depressive disorder, adult TRD, which is treatment-resistant depression, and for migraine, OCD, smoking addiction, and decreasing anxiety symptoms in depressed patients. And you may pay attention to there is more than rTMS, which is the ITBS, is also approved by FDA. So here are some international guidelines for TMS. This is the evidence-based guidelines on the therapeutic use of rTMS, and it has many recommendations for the actual use of rTMS. And for clinical guidelines in Canada, it has recommended rTMS as a first-line treatment. And in 2020, the TMS safety guidelines was updated, which before that, which has released in 2009, it has providing operational guidelines for the future use of TMS. So this is some recommendation from the evidence-based guidelines on the therapeutic use of rTMS. So compared to other neuromodulation therapy, such as ECT and DBS. So ECT, although it is a non-invasive therapy, it may cause memory loss and it may cause great pain on patients. So it may have need for anesthesia and oxygen inhalation. It may also cause headache, nausea, vomiting, and has a high recurrence rate. As for the DBS, the deep brain stimulation, it may need the installation of deep brain stimulators, and this brain stimulator may need battery replacement. So it is invasive, and the foreign body inflammation may cause some infections and rejection reactions. And both of these two therapies are of high cost, and their therapeutic effects need to be further demonstrated. But for TMS, it has evidence-based guidelines to ensure its efficacy, and its safety has been approved by FDA in many applications. And basically, it is non-invasive and it is painless, so it has no need for anesthesia, and it is also affordable, especially for TBS. So when you search TMS in PubMed, you will get many results, and you may discover that more and more researches has been done recent years. So we have mentioned before that the electromagnetic induction is a basic physical principle of TMS. So this time verifying pulse magnetic field form an induced electric field in the brain, and which generate induced currents. This current is small, so it is safe. And so this energy is converted non-invasively, penetrate the skull, and thus the underlying brain tissue is stimulated, as well as other cortical and subcortical structures that are connected to it. This picture shows a circular coil. This is a figure of 8 coil. And you may also see it in this picture, how it works. And some people think it may work on the pyramidal axons directly and causing the important depolarization and the hyperpolarization, as you can see here. So this is the resting membrane potential. This is the active membrane potential. And this hyperpolarization shows that it has increased the stimulus needed to move the resting membrane potential to the active membrane potential. So here is how TMS works. You put a figure of 8 TMS coil to stimulate the cortical neurons through the scape. And after that, the stimulation conducted by cortical spinal tract, and thus the MEP can be observed on the EEG. On the EMG. And this picture also shows how TMS worked to induce the MEP. So one of the important things for TMS is that it is not only a stimulating tool, but it can achieve neuromodulation. So one important thing about neuromodulation is the neuroplasticity. It means synapse. So this is a synapse. This is synapse, and synapse can comprehensively process various short-term information and stimuli received, causing long-term dynamic changes in the structure and function of the nervous system. So it is mainly manifested as LTP, long-term potentiation, and LTD, long-term depression. So when activities wire rapidly, neurons fire. Neurons that wire together. The synapse will be strengthened or weakened correspondingly as their activity is strengthened or weakened. This is similar to the obvious frequency dependence of RTMS modulation effect on nerves. And here is a picture of the simplified TMS circuit. When you close the switch, the capacitor is charged to a high voltage, and then it's discharged into the inductor, which stands for the stimulation coil. So the waveforms is also important for TMS. As you can see, these shaded areas is the periods of highest induced voltage, which make the neuronal membranes are most likely to be depolarized. And as for the monophasic process, it has a large initial peak and a much smaller, longer-lasting tail. Presumably, no biological effect compared to biphasic process. So nowadays, lots of TMS stimulators will apply the biphasic process. It is a cosine wave, and the later peak smaller than the first one because of the energy losses in the circuitry. And it can conserve energy by recapturing much of the original charge in the capacitor. It has greater biological effect for a given output voltage. And for a biphasic simulator, it is more efficient than monophasic ones, and it is suitable for rapid repetitive stimulation. Coils are definitely important parts for a TMS machine, and I have roughly divided the most frequently used coils into two kinds. First is the single coil. The flat circular coil really used a lot in clinical diagnosis, and it has a large stimulating area, as you can see here, and it is suitable for induced MEP and to stimulate the peripheral nerves, but it is less focal than figure-of-8 coil, as you can see here. And so it is difficult to determine the exact stimulation site. And one important thing about the flat circular coil is that a larger diameter coil may stimulate deeper, for it has more strong magnetic field. So here comes the two important coils. First is the flat figure-of-8 coil, and then is an angulated figure-of-8 coil, or you can see it. You can also call it a double cone coil, which are both double coils. So as for the flat figure-of-8 coils, it has been used a lot, and it is well focused, and the stimulation site is relatively clear, as you can see here, compared to the picture of the flat circular coil. And it is also a conventional choice for curing depression. So as for this double cone coil, which can stimulate deeper than the figure-of-8 coil, so this stands for the double cone coil, and it can achieve the best balance of the stimulation depths and focus. As for YINGCHI coil advantages, so this is a YINGCHI double cone coil, and as you can see, it can fit the brain well, and so because of the benefits of double cone coil, it can achieve earlier benefits, it hurts less, and all of our coils are of lightweight and making less noise. And here has an intensity button you can adjust the intensity very easily. So when coming to a TMS in assessment, the localization of the site is really important. And some of the operators, there are some frequently used sites, and they can easily find these sites, but for some other sites, if you just rely on your experience, this may not be that accurate. So we may recommend to use a positioning cap, which has predefined brain regions, and it is according to the International EEG 1020 system. So it has so this electrode is corresponding to this Brodmann cortical areas, and when using this cap, it is really easy to find the site the operator wants, and it is really accurate and efficient. So this international 1020 system is based on the relationship between the location of an electrode and the underlying area of the brain. These 10 and 20s are the actual distance between adjacent electrodes. So this is stands for 10% or 20%. It can help to maintain standardized testing. So if you want to find more precise stimulation site, you may also use a TMS navigator. Here shows the YINGCHI TMS navigator for coil positioning, and it can display the stimulation process and operation interface, as you can see here. So, and its error is really small, and combined with MRI or fMRI technology, the stimulation process can be visualized, and that's to guide the stimulation coil localization. So it is really convenient for diagnosing, delivering paper, and archiving. So we have introduced a localization of stimulation sites. Let me introduce some frequently used TMS protocols. There are mainly 4 TMS protocols. And for the single pass TMS, it is usually used in diagnosis and prognosis. And for the sham TMS, it is widely used in basic and clinical researches to ensure accuracy and effectiveness. And for the RTMS and TBS, they are used in clinical treatment. For RTMS, as we all know, it is a conventional TMS protocol. But for the TBS, it is an optimized protocol of RTMS. And we have mentioned before, it is approved by FDA in 2018. So for the single pass TMS, it means it produces 1 pass at a time. It can estimate the strength and excitability of the motor cortex and its descending pathways. The most important for single pass TMS is here, and we will explain it in details. So for an MEP, it stands for the motor evoked potentials. Basically, the muscle motor compound potential recorded in the contralateral target muscle by stimulating the motor cortex. And it is widely used in clinical diagnostic applications, and it is a monitoring of pyramidal tract functional integrity. So the MT stands for the threshold for producing an MEP. It reflects the excitability of the corticospinal tract, and also it is important in defining the dose of TMS treatment. And it can be divided into 2, the resting motor threshold and the active motor threshold. So the resting means this MT is measured with the muscle at rest, and both of these 2 need to measure by produce a minimal motor evoked response in at least 5 of 10 trials. And for the RMT, its MEP amplitude need to upper 50 microvolt in 5. And for the AMT, the MEP amplitude needs to surpass 200. Oh, sorry. So let's have a quick start of determining the MT. And here is a patient wearing an YINGCHI positioning cap. First, we need to find the Xili mark, and the Xili mark lies in the intersection of the lines between the preauricular points and the nascent ilium point. And they need to measure 5 centimeters lateral from the CZ point at the mark in red and start from the 5 cm point, measure 1 centimeters forward along the direction of the 45 degree of the mark in blue as empty reference point. So place a coil at the empty reference point at 45 degree angle, make it coincide with the stimulation center of the coil, with empty reference point as the center of the circle, searching the motor hotspot. So how to observe this motor evoked potential? I'm sorry to stop to pause this lecture. Can you hear my voice through this? Can we get the presentation? Can you hear me? How about other participants? Can you hear my voice? Okay, now, sorry to interrupt you. Let's go on. So how to observe this MEP? Some may choose to observe it by visual observation of the muscle twitch. So it may cause slight contraction of the contralateral APB muscle. It's about around here, or you can use an EMG to observe the MEP. And you can see here the minimal output of the motor evoked potential amplitude exceeding 50 microvolt for at least 5 times induced by 10 stimulations. So the central motor conduction time is also important, for it is a diagnostic test used to assess the function of the central nervous system, motor and sensory nerves. It refers to the time taken by the TMS evoked signal from the motor cortex along the cortical spinal tract to the spinal motor neuron. And if the CMC has a prolongation, the slowing of the conduction of the cortical spinal tract may suggest damage to the cortical spinal tract, such as damaged axons or changes in demyelination. And how to calculate the CMCT? You may also use this method to measure the CMCT. It is accurate, but it is time consuming. So this T1 and T2 is used a lot in determining the central motor conduction time. So first, the MEP waveforms recorded in the corresponding hand muscles after magnetic stimulation of the cortex. And here we get this TE stands for the MEP latency after cortex magnetic stimulation. And this T2 is measured when this stimulating the spinal nerves. So we get the MEP latency after magnetic stimulation of spinal cord nerve roots. And we minus TE by T2, then we get the CMCT. So for the silent period, first is the cortical silent period. So this is the CSP. And when the subject, it is measured when the subject actively contracted, the continuous electrical activity of the muscle was recorded. And at this point, a single TMS stimulation, a single pulse TMS stimulation is given to the contralateral cortex. As you can see here, and it can be observed that there is a period of inhibition of muscle electrical activity after TMS stimulation induces the MEP waveform. So after this MEP was recorded, the muscles would restore its EEG activity, and this suppression of muscle is due to the inhibitory effect of TMS on the motor cortex. So this ipsilateral silent period is similar to the CSP, for it is also detected when the subject actively contracts a muscle, and the single pass TMS applied to the ipsilateral cortex, as you can see here. So why we need to, how's the clinical significance of the silent period? The characteristic and duration of silent period have been the focus of many studies on mental illness. And there is more evidence that shows that there are changes in silent period in a variety of diseases. So as you can see in this figure, this is the evidence for impaired cortical inhibition in terms of mania using TMS, and it can also be used in TS, depression, and PD. So this may reflect that there may be direct or indirect changes in inhibitory pathways in these diseases. So the rTMS and TBS are frequently used in clinical practices. When you want to excite certain excitability, you may apply high frequency rTMS, which is bigger than 5 Hz, or the ITBS, the intermittent TBS, as you can see here. Or if you want to inhibit the neuron excitability, you may apply a low frequency TMS or a CTBS. As for the rTMS, it is the repetitive transcranial magnetic stimulation, and it has been used in clinical treatments and researches for many years. It outputs 2 or more series of regular repetitive stimuli each time. And as for the frequency, 1 Hz stands for 1 pulse per second, or you may call it 1 PPS. And 10 pulses in 10 seconds equals to 1 Hz. So let me specially introduce this TBS for you. Means this theta burst stimulation. It is an optimized pattern of rTMS. It can produce consistent, rapid, and controllable electrophysiological and behavioral changes in the function of the human motor. And its effects can last more than 16 minutes. And this is 2 patterns used a lot in TBS. And as you can see, it has a burst of 3 stimuli at 50 Hz. And the burst was repeated at intervals of 200 milliseconds, which is 5 Hz. So the treatment time can be shortened to a few seconds, or doubles of seconds, dozens of seconds. And this ITBS and this CTBS is used a lot. And as for the IMTBS, it basically have no effect on MEPs, and it is close to the baseline. So we may mainly talk about the ITBS and CTBS, and so these 2 patterns are crucial in determining the direction of change in synaptic efficiency. So this ITBS, it has 2 seconds train of TBS is repeated in every 10 seconds for a total of 190 seconds with 600 pulses, it can facilitate the MEPs. So as you can see, this 8 seconds has no stimulation. And as for the continuous TBS, it has 40 seconds train of uninterrupted TBS, which also contains 600 pulses, and the MEPs were suppressed and inhibited in CTBS. As you can see in this picture, this is a CTBS and this is the ITBS. So as for if you applied with 600 pulses in CTBS, the effect may last for more than 60 minutes. So why we said that TBS is an optimized protocol than rTMS, because as you can see here, TBS has lower intensity and shorter curing time, and has longer and more powerful after effects, and no side effects of TBS has been reported currently. So the sham TMS, means it is widely used in basic and clinical research in many fields, or it can mimic the sensation of TMS but will not induce an intracerebral current. And common sham TMS methods may include, they may reduce the stimulation intensity or reverse the stimulation side of the coil, or just let it 90 degrees perpendicular to the scale, but it has limitations for it is easy for subjects to find the difference from the real stimulus and doubt the authenticity of the stimulus. So as for the YINGCHI sham TMS, we have the use for single-blinded coils because it is easy to operate and it has the same sensation with the real stimulation coil, and thus it can improve the accuracy. And so it can implement the real stimulation on one side while implementing sham stimulation on the other side. So as for YINGCHI sham TMS coil, we have sham TMS system. We have both single-blinded and double-blinded coil. We have this IMF card and its host and reader. So it can intelligently switch between real stimulation and sham stimulation, and the sham stimulation may have the same appearance to the real one. So combined with this, we can probably to say it is used to reduce the interferences caused by the traditional placebo effect on the accuracy of the results. And the overall solution to sham TMS experiment, the sham TMS and the real TMS are kept almost the same in experimental operation and sensory effects. When applied with a 3D navigation system, it can further improve the repeatability of the research. So the safety of TMS is really important, and this is an update of the 2009 recommendations, safety recommendations. And so because TMS equipment is of large current, strong magnetic field, and has a high voltage insulation, so it may need to have various protections to the subjects and the operators. So as for the heat, because we all know that the induced current may produce some heat, and we need to have overheating protection. The temperature needs to be controlled under 42 Celsius. And as for YINGCHI overheating protection, it has the automatic system shutdown when temperature reached 41 Celsius. And so as for the heat problems, we need to have some liquid cooling system So the prevent of liquid leakage is also important. And as for some people, they may apply it with high frequency RTMS, it may cause possible induction of seizures. Although the seizure caused by TMS is really less possible, but we need to put some pause interval in this high frequency RTMS treatments. And because we need to pay attention to the coil lifespan, so we need to have some pulse counter. Also, this pulse counter can achieve more accurate treatment and also in research. So the safety of patients and operators need to be both protected. As for the subjects, they need to have the informed consent, and we need to know their medical history and their basic infos. And we need to have the emergency processing procedures in our treatment room or the clinical trial site. And as for the operators and doctors, there was no side effects or there was no damage report about them. And here seizures may be the worst case in the TMS AEs. And as you can see here, this is the rates listed in the safety guidelines. And so seizures is a worst term for the TMS, but the risk of RTMS in inducing a seizure is definitely low, and it is even low in patient populations, lower than patient populations taking drugs acting on the central nervous system. And if the TMS is operated under standard treatment, it is overall it is safe and reassuring. So the side effects in specific patient populations, as for patients with neurology and rehabilitation needs, such as the stroke or PD and AD. So here, a systematic review has been conducted on chronic pains, tinnitus, epilepsy, migraine, motor stroke, post-stroke aphasia, and pain. The risk of AE in epileptic patients is low, and other cases like thirst, there are only 2 cases, and their thirst immediately disappeared in both patients just after drinking water. And as for the seizures, no sequel and no recurrence was reported after the seizures induced by TMS. And the reason for why TMS may induce the seizures in these 8 cases may be it has used a too high intensity of stimulation, or it had a too short intertrain interval. So overall, when TMS is used carefully and under the standard, it is safe. So when people has Alzheimer's disease and a new multi-site and are applied with new multi-site simulation paradigms, there was no significant AEs. And it has been found that beneficial effects on cognitive improvement. So for people with diseases like depression and OCD, in all these cases, the psychiatric AEs induced by RTMS were transient and with a rapid spontaneous resolution after RTMS cessation, or parameters changed or promptly controlled by pharmacological treatment. And And this psychiatric serious AE occurred at a rate between 1 and 5%. So for treatment emergent mania, this rate is relatively low and may be lower than the natural switch rates in patients with bipolar disorders receiving mood stabilizers. And as for the patients with may cause some anxiety and irritability problems, it is mainly caused by the accelerated schedule of TMS treatments. It has 3 sessions per day for 3 days. So this is maybe too intense to these patients. And so the recommendations from the safety guidelines shows that indicate that no additional risk of major AEs in specific patient populations. So this is not a concern that needs to be taken into account. As for the safety on hearing, here is the recommendations also from the safety guidelines. When people has cochlear implants, individuals with this implants should not undergo TMS. And the risk of increased auditory symptoms, although it is very low, patients treated for tinnitus with hypercortisolism present before RTMS application near the affected ear. So it may need special protection. So on cognition at present, TMS does not appear to cause apparent lasting perceptual or cognitive AEs in healthy subjects. So as for the safety on pediatric, as for many single and ped pass studies, no serious AEs have been reported in these studies. And because the kids may have higher resting threshold for cortical activation, its stimulation intensity, when applied with higher stimulation intensity, it may link to increased discomfort and thus poorer cooperation. And as for the side effects, most studies reported no side effects, and some reported mild and transient side effects, such as headache, but these effects may be disappeared when TMS is ceased, and there has no report for serious AEs. And for the hearing in pediatrics, patients younger than 2 years may need specialized hearing protection. And as for patients elder than 2 years old, single pass and paired pass TMS is safe. And for many children, they are reported to have undergone this single pass, paired pass TMS or RTMS. And this also provides reassurance regarding safety of these technicals. As for TMS in pregnancy, non-invasive brings why choose this non-invasive brain stimulation? Because sometimes these pharmacological interventions for neurologic and psychiatric diseases in pregnancy are at times associated with risk to the fetus. And how the safety of TMS-induced magnetic field? Further studies of migraine patients during pregnancy assess TMS-induced magnetic field safety. And while the E-field electric exposure is close to nil, the major source of risk to the fetus is a TMS-induced seizure in the mother. So when people who are in pregnancy, their parameters need to be determined carefully. And in this study shows that mother treated with high-frequency RTMS for depression during pregnancy. So they did not present with increased perinatal complications and were within normal limits in both cognitive and motor development. So here is the recommendations from the safety guidelines. So based on the data largely with a figure of 8 coil, a cautious conclusion can be made that RTMS is minimal risk for the mother and child. So next are some evidence of the safety of TMS in clinical trials and research for patients with OCD. Despite the large magnetic field administered by a double cone coil, as we have mentioned before, the double cone coil has a deeper stimulation, can achieve deeper stimulation. It may cause some discomfort on people who are fragile. So the treatment was shown to be tolerable and resulted in no major side effects in these patient groups. For patients with major depressive disorder, and the safety of TMS has shown to be, these patients has shown to be well tolerated to the clinical trials, and no serious AEs has been reported. As for children with denied childhood epilepsy, so the magnetic stimulation produced no remarkable side effects in any of these subjects. And for people who have gait disturbance after stroke, there was no serious adverse events were reported in these patients. So that's all for my lecture 1. So do you have any questions? You can share in our this text. So let me see. Do you have any other questions? We can discuss it together. You can just list, or you can just write your questions in here.